That is fine. Functional diagnoses are both necessary for different reasons, and they will become clear as we go along. We'd like to tell you something that probably all of you know that was said, well, like almost 3,000 years ago by Heraclitus. When it comes to the development of the young brain, the only constant is change. So for us therapists, if we see a child that we can predict what he's going to do next, then we're a little bit concerned. And we will hear a lot more about complexity, but to us, development is more than just achieving milestones. It is building on complexity over time, provided we have a supportive environment. And we will hear a lot about that as we go along. So as we're looking at this baby who's 4 months old, actually looking at any child is a window into an infant's brain at that particular moment. Complex behavior, a multisensory behavior that is actually tapping on everything that's available to him or her, in this case, 4 months old. Obviously, she was given the opportunity to actively put the soother or whatever you call it in your countries into her mouth. She also has a good sense of her body because she realizes that she cannot do it just with the one hand and brings the other one in to help. She also knows where it's going into because she's preparing her mouth before she inserts. And that is just one small example of something that babies do every minute of their life, providing the parents don't come and do it for them. So the importance of activity. I would like to present to you a parent's view, and that is actually the main reason why I'm here with you. I present her in her own words, and this is what she said. She's a mother of a baby that was born at 24 weeks gestation. The baby was hospitalized for 20 weeks. On the third day, the family was told that there is a bleed, not a very localized one, in the right side of the brain. At the age of 1 year, the daughter was diagnosed with cerebral palsy, but therapy was started at 1 month's corrected age. In other words, well ahead of the formal diagnosis that was made, we think, quite late in this case. The mother said that the difficulty of the left side of the body was shown very, very early on. So again, parents are wise and they are actually our teachers about their children because they know their children the best. So she said it was important to her, the mother, to make sure that she can get early treatment as early as possible, even though the diagnosis, when given to her, was devastating in her own words. It was heartbreaking because she was already aware that there is really no medical cure as such. Well, as she went along, she read about stem cells and other things, and of course approached us caretakers. What do we know about things? But early physiotherapy, early and again early, appears in her dialogue all along, and we need to listen to parents. We also have to have some skills while we're working with parents. One of the most important things is to know their state of acceptance and their family makeup, their ecology. It guides us in the ways that we choose our words when we communicate with the parents. It guides us whether we need to have a psychologist present or to help the family decide to get the help of one. It guides us when we're setting goals that are specific, realistic in terms of that particular time and context. It guides us whether we need some bridging work to bridge between what we feel as experts in this field. I say that quite modestly, between our goals and the goals of the family. It also helps us to do some bridging work with the people that deliver the diagnosis. It guides us in choosing the amount and place of intervention, whether it will be in the family's home or whether it will be in the clinic or whether it will be in the school or preschool. For partnership, prioritizing and understanding family goals is the key to the success of any dialogue and intervention with the family. We know from the way adults learn that adults learn best when the information that are provided to them is relevant to their lives and that the learning occurs not in altruistic gray areas, but in real life context and addresses their specific needs, which change over the lifespan. We have to be aware of that as well. We also know from research that parental reports of skills and abilities are predictive of developmental delay. We will hear more about working with parents, environment, addressing complexity as we go along. Thank you for listening to me, and I would like to introduce and open the podium for the next speaker. I'd like to introduce to you Dr. Hadar Yardeni, who is the Director of Child Development in our Ministry of Health. She is also an ardent advocate for families and is very sensitive to family needs. And therefore, as a regulator, Dr. Yardeni, together with our National Health Insurance, have looked into how to alleviate some of the burden that parents, families have when confronting health authorities. Thank you, Dr. Yardeni.
Thank you and good afternoon. In my short presentation, I would like to talk with you about the changes we made in my office together with the National Insurance Institute in Israel called BTL in order to help parents of a child with CP. So what is the Child Insurance Institute? The Child Insurance Institute is a statutory office that operates under a law from 1995. It acts as an insurance company. It is a compulsory insurance. Every resident of Israel must pay national insurance contribution, even people who do not work. But the premium is not determined by the risk levels of the policyholder, but by his ability to pay, according to his age, according to his income. In this matter, people that earn a lot pay more. The payment divided between the employee himself and the employer. And I would like to quote from their website as they wrote about the subject. The National Insurance Institute is aware of the heavy burden borne by families who raise a severely disabled child, and it therefore participates in covering the expenses that such families pay in this context in order to somewhat lighten their burden and to enable the disabled child for a normal life. Insofar as possible, within the family and the community. The BTI has a long list of reasons for benefits. One of the reasons to get benefit called dysfunction of two limbs. We know that these children have disabilities, more difficulties in their peers. They have problems to perform actions such as standing, walking, holding objects, and eating, and the parents may be entitled to a disabled child allowance from the age of 91 days to 18 years and 3 months. The payment based on the performance and the child age and the degree of disability. In this way, parents to a child with dysfunction in a pair of limbs can get 50% of the benefits. Parents to a child suffering from a complete loss of functionality of a pair of limbs can get 100% of the benefit. Child that depends on his parents and other for basic ADL, such as walking, bathing, eating, and so on, can get from a partial to complete dependency from the age of 3 years. And if a child is completely dependent on the help of others or need a permanent medical attention, he can get even 188% of the benefit. So all I said until now sound great. So what is the problem? When we looked into that, we found that parents with toddler with CP, only few of them got these benefits. We found that the kids and the parents needed to come time after time to these BTL committees, to a neurological assessment, and most of the time bought papers that didn't meet with the demands of the people in the BTL. They needed to come to the committee and show the child's disabilities, and it was very unpleasant for the parents. Therefore, we decided to gather a committee with a therapist that have the most professional knowledge in the subject. This include doctors from the orthopedic, neurological, developmental type, and also physiological therapists, occupational therapists, and so on. So we had 3 goals for this committee. First, we wanted to have decision based on international tools used by the Child Developmental Institute. Second, to have an agreement about the information that need to be sent to the Institute. And third, and not less important, to make a way of getting the benefits without the need to come to the medical committee. The committees agree and recommended on that. The motor function of a child in the lower extremities will be determined according to the GMFCS test, as ambulation can reflect on function. The child motor function in the upper limbs will be determined according to the MAX test. The information will send to the institute by the family, but they will not need to come for the committee. We also agreed on the amount of benefits that the family will get, and you can see it in this table. It's going in one side, the GMFCS from level 1 to level 5. On the other side, the MAX from level 1 to level 5. And you can see that some families will not get any benefits. Some of them will get 50% of the benefit, and you can see that most of them will get full benefit according to the child abilities. But we still have some problems. There is a problem to use the MAX before the age of 4 years, as it has found that this is an unstable measure before this age. Therefore, the benefits criterion for a child younger than this age is based on a clinical judgment in the 2 limbs disability section. It is also difficult to accumulate developmental therapies to use this GMFCS and the MAX. Today in Israel, the GMFCS is more acceptable. But it is very important to say that we have regulations and we have interpretations, and our desire is to define a wide and considerate interpretations. Thank you very much.
Thank you, Dr. Yardeni. We know you're an advocate for families and their needs. I'll just challenge you with one other thing. Can you please mute yourselves, whoever is unmuted? Hala, can you please mute yourself? Thank you. As I was saying, the thing that I would like to challenge you with, if I'm allowed, is communication. Participation in society is not only dependent on mobility. It is mobility and communication. And the other thing is knowledge translation. It takes a very long time for knowledge translation from the research to come to the field. So I think as a neurodevelopmental therapist, as a Bovas cerebral palsy therapist, I would recommend that the Ministry of Health uses the Minimax for children that are under 4 years old, because you can see the difficulties in feeding and fine motor abilities and ADL from a very early age on. Thank you very much. Thank you.
Okay. I will just answer you that when we work on it, they didn't have the Minimax yet, but afterwards we also asked them to use the Minimax. I think Dr. Bresner, that will speak after me, that also sits in this committee, maybe can tell about it a bit more than me. But yes, indeed, we asked them to take the Minimax as the test that can help them to give the benefits for children younger than 4 years, from the age of 2.
Well, that's great to know. Anyone else would like to make a comment on this? We have another few seconds. Okay, Nava, here you go. It's my pleasure to introduce to you Nava Gelko. Nava is an experienced physical therapist who is a doctoral candidate at Haifa University. She's also the chairperson of the Child Development Centers Association in Israel, and she's also the director of the professional team at Keren Or Preschool. Nava will talk to us about the correlation between participation, environment accessibility, and quality of life in children with cerebral palsy who are mainstreamed into a school in Israel. Thank you, Nava, for being with us and sharing.
Thank you. And you can see the presentation and can hear me, yeah?
Yes, we can, Nava.
Just to check. Thank you. So thank you, Dr. Kopelovich, and thank you for inviting me to share with you our recent research results that has been done as a part of my thesis in the Occupational Therapy Department in Haifa University with Professor Batya Engel-Yeager, my supervisor. After 25 years working as a PT with families and children with cerebral palsy from birth to 21 years old, and with the change in accessibility law, and with the integration of children with disabilities to regular primary schools in Israel, I wanted to look at participation levels in children with CP in comparison to children with typical development, at the influence of functional ability levels, level of classification, environmental barriers and support on participation, and to explore the correlation of those elements to quality of life. I want to share with you Taylor's movie that maybe some know. that emphasizes the topic. It was introduced to us by Professor Palisano a few years ago in our Israeli Association annual conference. I'll show you only a few short parts that I cut and put together, 2 minutes long, and recommend you to watch it fully online.
Hi, I'm Tyler. Since you're here, I'd like to take a few minutes of your time to tell you a little bit about myself. I guess I'm just a normal high school sophomore. I love video games and movies, especially action movies with lots of martial arts. You know, Jackie Chan, Bruce Lee, Jet Li. I take karate lessons myself, the Shinkudo style. I'm a yellow belt with a blue stripe. I've got great instructors. They're called senseis in karate. I had to stop taking lessons last fall because of marching band practice. We've got an awesome band. Our director works us hard. I'll never ask more than your best, he always says. After school on Mondays, I have scouts. In fact, if you're watching this, which I hope you are, I'm an Eagle Scout. But before I go, there's one more thing I should tell you. You knew there was going to be one more thing, didn't you? Well, I'm not really Tyler. My name's Chase. I'm an actor and a friend of Tyler's who was very happy to help him out. Tyler's here too, but before you meet him, I want to assure you that everything I told you about him is true. All of it. That's Tyler's life though, not mine. And he'd be the first to tell you that he didn't get there alone. I think he'll want to talk with you about that. Come to think of it, do any of us get there alone?
I don't think so. Yep, I'm Tyler. Surprised? Why? You shouldn't be. Chase described the life of a typical high school kid. Well, that's me. Sure, I got a couple of things to deal with, don't we all? I want to talk to you about the people who saw me, who made the effort to see me, Tyler, not a diagnosis.
So environment matters, and environment includes not only physical accessibility, but people attitude and perception, ability to get all sorts of support from the state by law, the knowledge and ability of individuals and families to get information, and much more. Can we show that in our research? We start the steps of the research on participation, quality of life, and environment in children with CP and physical disabilities who are integrated in regular school by first looking at the literature. In the literature, we find that children with CP have low level of participation comparing to their peers. Their parents and also adults with CP report on low level of quality of life. Low level of participation has been shown to influence quality of life, and some recent research highlight the environment as an important mediator for children participation. In our research, we wanted to further explore the correlation between environmental factors, participation, and quality of life. We approached 30 children with CP and physical disabilities in primary schools from all over Israel, and 29 children with typical development, each from the same class. Their parents answered the PEMCY questionnaire, which is the first tool that assesses both the level of participation in everyday activities and the existence of environment support and barriers resources in all three environments, home, school, and community. They also answered the quality of life questionnaire, and we graded the classification levels in the CP group. The findings show that children with CP had significantly lower participation and quality of life levels in comparison to children with typical development. When we looked further to the component of participation and environment, we found that the number of activities and participation frequency were the lowest in the community environment, with low involvement, low environment resources, and high desire for a change in all three environments. We find higher participation and involvement in activities the child performs on their own, such as computer games, watching TV, talking on the phone, and decreased participation and involvement in activities requiring social interaction and participation in structured community activities. The findings are consistent with previous studies that showed higher participation levels in informal activities the child usually performs on his own, instead of formal activities which have rules and goals. When we looked at the correlation between the component of the PEM-CY questionnaire and the quality of life questionnaire, we find a high correlation mostly in the environment, resources in the community. And when we looked at the child factor, it was correlated mostly with the GMFCS, the motor function. However, with the regression test, we found that the primary predictor of quality of life level in 37% was the existence of supportive resources in the community. So environment in all its aspects matters. We found that the primary predictor, especially in the community, and for all children with CP in all levels of function, and we need to change our clinical approach. Previous studies have shown that participation in leisure activities positively affect the quality of life more than structured daily activities. It is essential to guide intervention program to strengthen integration in community life, in leisure time from an early age. Approaches such as PrEP, which is an evidence-based intervention that focuses on enhancing participation through modifying the environment and recently showed improvement also in physical functions, are probably preferable for the improvement of participation and quality of life level. But it is not enough. A survey that has been done here finds 90% of parents prefer that children with disability won't participate in an afternoon activities with their child. We need to educate and change the community perception for a full inclusion. Children with CP and children with disabilities are entitled to get the same opportunities as other children. Let's hear Lavi's mom, a child 4 years old with CP, firstly in Hebrew, and then I will quickly translate to English.
אחר הצהריים אנחנו בעיקר עושים או פיזיותרפיה או הידרותרפיה, או שנפגשים עם חברים, בעיקר חברים שלי שיש להם ילדים בגילו. אני הייתי שמחה יותר, לפחות בעתיד, לשלב אותו גם עם ילדים שאני לא מכירה את ההורים שלהם, ילדים אחרים, גדולים יותר, שיהיה ניתן לשחק ככה ליד הבית, או בפעילויות מהנות אחרות, עם מתקנים מותאמים, או שלא, קצת יותר מגוון. לוי מאוד מאוד אוהב ילדים והוא אוהב אנשים. טיפוס חברתי, טיפוס כמו כולם. להתראות.
On the afternoon, we mainly do PT or hydro, or meet with my friends who has children in his age. I would like him to meet with children that I don't know their parents, other children, older, to play with them next to our house, with or without accessible facilities. More variety. Lavi likes children, he likes people. He's a very friendly person, like everyone. Thank you very much for listening today. And I want to thank all the wonderful parents who participate our research. I will finish my talk with Taylor's word. Would you make the extra effort if you knew it would make a big difference in someone's life? Of course you would.
Thank you, Nava. And if you allow me, I would like to read the sentence from this month's October Developmental Medicine Child Disability that actually confirms this message that Nava gave us. So this is an editorial by Anna Basu, and what she is talking about is social prescribing. And she says, relies on matching locally available community assets to the needs and interests of the client. And she recommends that it be done by a link worker that will link the needs of the family to the regulator and to society. I think that really, really confirms what you said. Thank you, Nava. Anyone else would like to comment on this? You can write it in and we will get back to you. Right. So now it's a privilege always and a pleasure to introduce a wise pediatrician and a mentor at times, Dr. Avichai Bresner, pediatrician, former director of Department of Pediatric Rehabilitation at Safra Children's Hospital on the Shiva Medical Center campus. And he will present some lessons learned about functioning and a good enough professional. Dr. Bresner, you take it from here.
Thank you very much. Can you see? Yeah. Okay, I'll try to discuss today the issue of functioning and the good enough therapist or professional. When we speak about functioning, we speak about what people do in a certain context. And we use the ICF framework and we use the activity participation together when you refer to functioning. And there are constructs, performance construct that the ICF demand. It's what a person can do and what a person actually does in his current context and in an idealized context. The ICF is very broad and wide, and it starts when speaking about functioning from very intimate, intra the head, in the head functioning of thinking and communicating, etc. And continues through mobility and self-care and domestic life, and ending in the wide community with political life and community life and social activities, etc. So it's very, very wide and broad. The lessons that I would like to speak to you about today are these. I think there are two conflicting action logics. I will explain shortly about complexity, about context, about normativity, and also about discrepancies or multiple informants. All I'm talking about, of course, I learned from the literature, I learned from my practice, I learned from therapists, I learned from my patients. And but what I'm presented here is all mine, so I'm to be responsible. Conflicting logics. Okay, WHO defined rehabilitation as a set of interventions designed to optimize functioning and reduce disability. Okay, and of course, in the context of the environment. So if you read it carefully and we take our experience with us, there's two ideas that conflict or complete each other. One is functioning and one is dysfunctioning. And I think there are two conflicting logics here. And logic is a set of agreed upon conventions for thinking, expecting, acting, etc. One logic is achievement logic. And then when we are using it, we speak about goals, motivation, engagement, mastery. And the most common word used is progress. The child is progressing. There's another one, adjustment to deficit logic or deficit logic. And we speak about adjustment, coping, trauma, and the major issue here is acceptance and resilience. In rehabilitation practice, and that's I learned for many years, one can deal only with one logic at a time. These are two very different mindsets, okay? And the tension almost never completely goes away, okay? This ongoing negotiation, it's a lifelong, it's a life course issue, and I am just saying it in one slide. I move to complexity. ICF is a very complex framework, and we should remember that it's only a framework. It's not an action plan. It's not something we can do. It's just something we can think with. These are concepts. And the relationship between factors here is very complex and very compound. And you have to pay attention that you go from the biomedical issue to the environmental issue to the psychological issue and combine them together. So it's a very complex framework, and it's not action plan. And if you try to make it to an action plan, so you get all these, just eyeball it and see how complex they are, these models. One on the left is a model of how much therapy, okay, you should give a patient, okay? And you see how many factors are involved. In the middle, you can see a psychological model of post-traumatic reactions through time. And you see that it's very complex. And on the right, quite recent framework for transactional processes or interpersonal processes involved in rehabilitation. So if we want to make the ICF practical, okay, we need very complex model to understand and predict and do whatever we can do. To summarize, humans are very complex and humans in situations are more complex. And you should remember that many processes of social exchange, teaching and learning and hands-on are involved in the rehabilitation. Team effort is well known to be very complex. Families are complex, and interaction with technology are not intuitive, are not simple, they are very complex too. Now context. The physical context is nowadays well known. I mean, everybody speaks about it. And I want to emphasize the contextual, psychological, social, cultural, political. These are hidden, okay? We have to observe, we have to interpret, we have to judge in order to decipher prejudice, discriminations, in order to know norms, beliefs, and values, and also policy issues. The policy is out there. We are using it. Is everything, it's okay? The message. Okay. And the families, you must know, if you don't ask them about the feelings and motives and norms, they won't tell you. You see the window here?
Yes.
Who put it here? You see my slides? I have a message here that I cannot, oh, now, thank you. Normativity. There are two, the accepted use of normativity is how it appears again.
What you can do is press the presentation mode, Michael, and then it will probably work better.
Where is the presentation?
If you look for present from this slide, then you will probably be able to work on it.
Okay, I don't find it that way. Yes, so. No, it seems like it.
Press F5 is being said in the chat box. Yeah, this is good.
Good. No, it's still there. Okay. I'm sorry for the delay. I can do it. It's something central. So I'll get along. Okay. We have, when we speak about normativity, we usually speak about prescription, how certain group of people ought to function in a context. But there is also a descriptive meaning to normativity, how a certain group of people is functioning in a context, what is normal for them. And I would like to avoid using the word normal, because then you refer to typical development. And the basic idea here, the children in YAS with certain impairments function differently. They cannot function as other typical persons do. And we should, and we accumulate knowledge about the functioning of people with impairments in environments, and we know how they actually function in these environments. We cannot change this level of functioning. That's very important. And hence we should strive for functioning in this descriptive level. It's true if you take the ICF classification up to the level of domestic life. Beyond that, in the social realm, as Nava said before, it's completely different, and the environment should be changed. So what I'm suggesting that we use the descriptive knowledge we gain about people with disabilities and make it prescriptive, make it our own goal to function, to do. And then more basic ideas, we should strive to a typical everyday level of functioning according to these norms. But if we do not have norms, or if norms are irrelevant, and until further advancement in our knowledge, we should do intervention based on how we measure the change if we intervene, what we call response to intervention. We should not strive for peak or outstanding performance achievements, because it would not last, it will disappear. We can work for the Paralympics, but the Paralympics is not in the kitchen at home, it's somewhere else. So in order to last, a way of functioning should become a habit through socialization. So socialization means what every family does at their home, at its own home. And just here you can see, when I speak about normativity, you can see exactly how normativity is seen in graphs. You take the GMFM and you get the GMFCS, and you see that some level of functioning with the GMFM, which is a proxy for impairment, gets a meaning in GMFCS. The same, you take the GMFCS and you see how the PEDI, and I'm not getting into these measurements, mobility is spread, okay, according to the level of GMFCS, etc. And again, with FCS, with FSS self-care. And here, much more obvious to the eye, if you take the Vineland measure of adaptive behavior, which is very sensitive to intellectual disability. And you see children on the left is out and children on the right is, how the function is spread, and you can see that you can differentiate between children with intellectual disability and without intellectual disability. However, the Vineland is not very sensitive to the level of functioning like the PEDI. So you have to find more instruments, you have to find more measures, you have to develop theories of measurements in order to refine the specification of normativity. just in response to intervention, it's the problem-solving circle that you are well aware of. And the last issue I would like to describe is multiple informants. Multiple informants is common in our business. People say or watch or observe different things about the same phenomena. It's well known in quality of life. It was described many, many times about quality of life. Parents do not know exactly the quality of life of their children. Okay, they can guess, but they are not inside their children's head. It's happening in the typical population. It was described in children with cancer, and it was described again and again. Look for the work of Ellen Colbert in Europe in children with cerebral palsy. Mm. But it's also true for functioning. And this is a study we did about 10 years ago, and you can see that the red line is if there is complete congruence between parents and healthcare workers. So we took the child, we examined and watched his ability to perform. And if there was full congruence, that's the red line. But actually we found the line with the circles. And you see deviations. So the child can function differently at home and differently at therapy, or in the eyes of therapists, or in the eyes of the parents. It's not important at all who is telling the truth or not the truth, okay? It's not important. Important is there's a gap between observations. And you can use this gap to understand what's going on, okay? And I believe, for example, that at home, with the rush of the morning and the need to send children to school is responsible for these differences, for example. But there are many more explanations. So to summarize, the lessons for the good enough professional, and the good enough professional is one who knows his limits and also knows when not to intervene and what should not be done, is that disability is a social issue. It's not medical or educational or welfare. It's more than that, and even more than that. Conflicting logics, you should be aware of that and plan in advance. That's in a nutshell. Complexity, at any time we see only part of the whole picture, and we should know that. Okay, and we cannot cover the whole picture. Context, be aware of the possible hidden aspects, and you should talk to families, and I think even better, devise and use protocols. And normativity, okay, we should strive for normative functioning for our children with disabilities. And when we don't have norms, we should use response intervention, but use it wisely. Habit and socialization just provide you with typical normative performance. And multiple informants, yeah, I believe it's unavoidable in our clinical practice. And this can be an opening for intervention. And we should try to explain the gaps between observers. Thank you very much.
Well, thank you, Dr. Bresner. A presentation that actually warrants a whole hour. An interesting, can you hear me?
Yeah.
Yeah. An invited editorial, again, this month's DMCN actually addresses some of the things that you referred to, but from another point of view. And Dr. Novacek asks, will individuals with cerebral palsy have better musculoskeletal outcomes in 30 years from now? Well, I can tell you, thinking back 40 years and some or more, that if the knowledge that is available today was available 30, 40 years ago, do I think that the outcome of children would be better? Well, again, it comes down to their environment and their socialization, which is some of the things that you have mentioned. He says, Dr. Novacek, that there is slow implementation of knowledge. In other words, knowledge translation takes a very long time to come down from, let's say, the ivory tower of research to the clinicians on the ground. And that collaboration between researchers and clinicians should be something that we should strive for. The other thing that he says is missing very much is the natural history of cerebral palsy, that if we understand better impairments in childhood, will we understand better how to increase their mobility later on in life? I would like to make a personal comment here. There is a great deal of talk about mobility. The GMFCS has added a great deal to our way of better understood communication between us all. But again, it's talking about mobility. And in order to really be an upstanding citizen and to be able to communicate, we need a supportive environment and the complexity of human interactions with one another. And this is something for us to think about. Interaction requires communication, and we need to look forward and provide faster communication devices for children. I would like to thank all of you for your very wise presentations. Thank you very much. We have a few minutes if someone would like to make some comments or ask some questions. I see Dr. Bresner. Yes, please go ahead.
If I may make a comment, okay, the wise person should sometimes refrain from intervention. And that's I add to Dr. Novacek's speech, because in many cases, you should do nothing. Refrain from doing anything, okay? Don't intervene, okay? And if we can change what happened in the last 30 years, many interventions we should not have done in all these years.
Well, that's very thought-provoking what you're saying, and certainly a great deal of challenge for clinicians that are engaged during the day and sometimes even not during the day in thinking about interventions. But I would like to ask you in return, if I may, how do you deal with parents, families pressuring for more and more intervention? That even if you engage with a child in a play activity, which is a window to his brain, actually, the parents often think that you haven't done too much. Give us some insights from your experience.
Well,
how do you deal with it?
It's very complex and complicated, and it's a matter of culture. We live in a culture of intervention. We live in the culture of personal responsibility, okay, in the last 40 years or so. So it's very difficult. And you have to convince the parents that it's not the rule that as much you intervene, the much you get. Sometimes the opposite. There's a good enough quantity of intervention, if I may say so. And it's a measure of trust. Okay? If you gain the trust of parents, they can believe you. And it's complex.
Anyone else would like to say something? I would, if nobody else does. It depends how we define intervention. Okay? for a therapist, cerebral palsy therapist intervention is sharing with a parent the skill to help the child and themselves to do daily things in a specific way that might maybe minimize shearing effects over time. That we see over time, that is one thing that is common to most types of cerebral palsy, is shearing effects on the musculoskeletal system, which leads to pain, often sleepless nights, lack of energy, and isolation. So what is intervention? And how much of a burden can we put on parents? And is it a burden if we manage to give the parents skills to care for their child in a way that also reduces the shear on their own bodies? That is not intervention.
That's what I said about logic of acceptance. If you accept a certain level of functioning, and that's going to be the future of the child in terms of functioning, not in terms of life. Okay, so there's a list of interventions that can be done also by parents. Okay, to make them confident about themselves. One of the explanations that we thought about the discrepancy is nobody taught them, okay, about the normativity of functioning of children with cerebral palsy. So they don't know. They actually don't know how their children should function. Okay. So this is
I want to add, I agree so much with what we are saying. I think parents need to go through stages, but I think and it's about, okay, we are Israelis, we have our own, attitude, but it's, as a physical therapist and as therapist, it's our responsibility to give the information slowly, and to know how to talk and how to use the terminology. And I think sometimes we as a therapist can ruin and can build. So it's not that we can change completely their perception, but I think we can influence. And I think this is something for us to think about, and how we approach, and what we call intervention. They don't know, they know from us. So I think it's a slow process that I think we can influence.
I'm sorry to intervene.
On this positive note.
Can I say something, Sarah? I'm sorry to intervene, but it is 12 o'clock.
Yeah.
And we have to close this session, for there are other sessions around the world that will need a Zoom link.
Johannes, thank you very, very much for your support all through this, and thank the organizers in our name for going ahead to listening and sharing. Enjoy listening. Thank you very much.
I will do. Thank you very much for being here and organizing this session. Have a good day, you all.
Thank you. Thank you.